So I had the honor of authoring the Mental Health Parity and Addiction Equity Act of 2008. We had it further incorporated into the ACA in 2010. And of course, just last November, we finally got the final rule implementing this administratively. And it goes into effect in July of this year, in just 2-3 months from now. And then, of course, next January 2015, more health plans really will finally be covered under the parity law. What I'm interested in is working with the insurance community to really develop a process by which we get consensus on what it is that constitutes mental health. And the way we do that is we bring in both the providers and, most importantly, the consumers with the insurance industry and really have an open discussion about what works, and if it works, then obviously we want it paid for. So I think there's a process of negotiation here. That process can happen through litigation, but and I'm sure there will still be litigation, but if we can start to define the basic elements of what there would be consensus about, if you can believe it, consensus from consumers about what they need and what works for them, is frankly going to help demonstrate to insurance companies that they can be meaningful results if a capitated model of care that incorporates the services beyond just the, quote, medical services, but the human services, the social services, the housing services that are going to be so essential to someone with a mental illness or substance use disorder being able to achieve a reduction in their symptomology. And with the reduction in their symptomology comes a reduction in their utilization of services. So where you start with all this, I like to point out is the kind of examples like Judge Leifman has done in Miami-Dade, where he has been in charge of how the budget is written to help reduce the costs of those with severe mental illness who end up in the prison system. And of course, they are the first point of entry for us to demonstrate this concept that if you bundle these corrections dollars with the housing dollars, the human services dollars, the case management dollars, the housing dollars, you get to save dollars from each of those budgets in a way that can demonstrate to the payers, i.e. the people of the state of Florida and the federal government, that this is worth investing in. So what we need to do in mental health is prove the point that investing in mental health saves dollars, because it's going to save dollars in compliance management for people with diabetes, cardiovascular disease, other chronic illnesses, reduce the comorbidities of people who have a dual diagnosis. And that, I think, is one area of savings. The other areas of savings are in these corrections budgets and these other budgets. What we need to do is have a much bigger picture of what it is that we need to construct in terms of the financial package that will, allow us to truly build out the services that will treat these, biopsychosocial, recovery models, because it's going to take all. It's going to take the bio, the medical, it's going to take the social, and it's going to take the mental health, all of them tied together to really achieve the savings that we know are there if people are managed much more effectively in terms of their illnesses playing havoc in their lives. So I am anxious to talk to your members about how they intend to go about this and to work with them to bring both the provider community and the consumer community to the table. We started to do this in the Kennedy Forum up in Boston last October. It marked the 50th anniversary of my uncle, President Kennedy's signing of the 1963 Community Mental Health Services Act. And what that represented is the vision that we actually need to follow today. And that vision was we ought to provide for people in their community, support independence, but the way to do that is through research, so you get better treatments, and prevention. Those were the three prongs: community, research, prevention. That is the model that was to substitute for the institutional model that prevailed when President Kennedy first took office. As you know, we never fully funded those initiatives in terms of community-based models of care, and what ended up happening is people got reinstitutionalized from psychiatric hospitals to our jails. So that is still a challenge that we have to overcome, but I still think my uncle's vision of what was needed is very much alive and well in terms of its practicality in today's environment.